Hi all. Let's learn today about the practical aspects of forceps delivery. Forceps delivery is a form of assisted vaginal delivery that can be used in the second stage of labor to expedite delivery. Delivery by forceps may benefit both the mother and the baby and reduce serious morbidity that would be associated with prolonged delays in a second stage of labor as well as cesarean section in second stage.
Types of forceps: non-rotational forceps and rotational forceps. The term rotation refers to the angle between the sagittal suture on the fetal head and the AP diameter of the pelvis. Non-rotational forceps: outlet forceps like Wrigley's forceps, which are short and light and are used when the head is on the perineum, that is +3 station. Here, the angle of rotation typically is 0 and not more than 45 degrees. Mid-cavity forceps, that is Neville-Bahn forceps or Simpson's forceps, are used when the sagittal suture is in the anteroposterior plane or at least not more than 45 degrees from the midline. The second type of forceps is rotational or Kieland's forceps. This is used for rotational delivery when the sagittal suture is more than 45 degrees from the AP diameter of the pelvis. The reduced pelvic curve allows rotation about the axis. Coming to parts of forceps, for the purpose of demonstration, we have the outlet forceps or Wrigley's forceps. A forceps typically has two blades. The left blade goes to the left of the maternal pelvis, while the right blade goes to the right of the maternal pelvis in this manner. This is the articulated state of the forceps. This is the toe of the forceps. These are the fenestrated blades. This is the heel. This is the shank. The forceps has different types of locks. This is the English lock and this is the handle. This is the pelvic curve. This is the cephalic curve. Coming to classification of forceps. Forceps application is said to be outlet forceps when the fetal scalp is visible without separating the labia. Fetal skull has reached the perineum. Rotation does not exceed 45 degree. It is said to be low forceps when the fetal skull is at +2 centimeter, that is +2 station below the ischial spine, but not on the perineum. There are two subdivisions: non-rotational, where the rotation is less than equal to 45 degree; rotational, where the rotation is more than 45. Mid-cavity forceps is fetal head is no more than 1/5 palpable per abdomen. Leading point of the skull is at station 0 or +1 centimeter. Two subdivisions: non-rotational, that is less than equal to 45 degree; rotational, more than 45. Coming to the basic principles of forceps application. Cephalic application. All applications of the forceps must be cephalic. Irrespective of how the baby is oriented in the pelvis, the blade should lie evenly against the sides of the head. Coming to cephalic application in occipito-anterior position. The application should be along the occipito-mental diameter, with the fenestrae including the parietal bosses and the zygomatico-temporal arch, and its tips lying on the cheek. So for the diagnosis of proper cephalic application, we need to take into account 3 points: the posterior fontanelle, the sagittal suture, and the fenestration. The posterior fontanelle should be 1 finger breadth above the plane of the shank. The sagittal suture should be perpendicular to the shank and equidistant from the plates. The fenestrae should allow 1 fingertip between the blade and the skull.
So while following the principles of cephalic application, we must consider the position of the baby within the pelvis. In an occipito-anterior position, the forceps would be oriented in this manner so that they lie equally on either side of the baby's head. In case of right occipito-anterior position, the forceps would be oriented in this manner if cephalic application is used. In left occipito-anterior position, the forceps would be oriented in this manner.
Coming to pelvic applications of forceps. Here the left blade would go to the left side of the pelvis. The right blade is on the right side of the pelvis. The concave margin is towards the symphysis pubis, while the convex margin is in the hollow of the sacrum. And this application is done irrespective of how the baby is oriented in the pelvis. Thus, it increases the risk of injury to the baby, hence, it should not be performed. Coming to prerequisites for forceps delivery. On examination, that is abdominal and vaginal examination, ensure that the head is less than equal to 1/5 palpable per abdomen. Cervix is fully dilated and the membranes ruptured. Station is at the level of the ischial spines or below. Position of the fetal head has to be determined. Caput and molding is no more than moderate. Pelvis is deemed adequate. Preparation of the mother. Clear explanation should be given and informed consent should be taken and documented in women's notes. Trust established and full cooperation sought. Maternal bladder should be empty. Appropriate analgesia should be in place. Indwelling catheter has been removed or balloon has to be deflated. Aseptic technique followed. For the preparation of staff, operator has the knowledge, experience and skill necessary. Adequate facilities are available, including the equipment, bed, lighting and access to an operation theatre. There is a backup plan available, like to allow a cesarean birth, anticipation of complications that may arise, personnel present who are trained in neonatal resuscitation. For consent, for birth room procedures, verbal consent should be obtained prior to assisted vaginal birth. For mid-pelvic or rotational birth, in case shifting to the theatre is indicated, a written consent should be taken. So before application of forceps, we must perform a per-vaginal examination and determine the position of the fetal head. Phantom application is done outside the maternal pelvis to identify the left and the right blades. The blade to the left of the mother would be the left blade and the one on the right of the mother would be the right blade. Lubricate the blade, and for LOA and OA position, the left blade has to be inserted first. The patient should be in the lithotomy position and the mother's perineum should be slightly overhanging the edge of the bed. The operator places his or her back to the maternal right thigh and holds the handle between the fingers as in holding a pencil. The shank is held perpendicular to the floor. The middle and the index finger is introduced into the vagina and the thumb is applied to the heel of the blade. The force necessary to insert the blade is exerted by the pressure of the thumb. The left hand guides the handle in a wide arc until the blade is in place, as shown.
Once in place, the blade should be held by the assistant. The right blade is then inserted in a similar manner with the operator's back to the patient's left thigh. If correctly applied, the two blades should lock easily, but locking does not have to be maintained throughout, only when pulling. Check correct application using the landmarks described previously. Traction is applied with contractions. The operator should be seated in front of the patient with elbows kept pressed against the sides of the body. To avoid excessive force during traction, the only force exerted should be that which can be exerted only through the wrist and the forearm. The Paget-Sextoff maneuver provides the best grip for exerting traction. The left hand grips the shank and exerts a downward pull. The right hand grips the handles and exerts a pull parallel to the floor as shown. The force exerted in each direction will determine the vector of the force. The traction force should gradually increase, reaching its acme at about 30 to 40 seconds and then gradually relaxing. For the resident being taught, it is instructed to actually count off the seconds out loud so that they can appreciate the time involved. Between tractions, the handles are unlocked to relieve pressure on the fetal head in this manner. An episiotomy is usually required at the time of crowning. When the occiput comes under the symphysis, the head can gently be extended with one hand on the forceps handles. When the extension is almost complete, the forceps can be removed, right blade first and left blade second. And the delivery completed by the Ridzen maneuver.
So hope this helps clear basic concepts of forceps application. Forceps delivery is indeed an essential skill for a birth attendant, as it would reduce the maternal morbidity as well as fetal morbidity if applied by a skilled birth attendant after fulfilling the prerequisites that are necessary for forceps application under appropriate indications.